Welcome, everyone. I'm Bill Sappenfield. I'm the director of the Florida Perinatal Quality Collaborative here at University of South Florida College of Public Health. And I'm glad to be in partnership with the Joint Commission on this new initiative on levels of maternal care verification here in the state of Florida. This is going to be sort of a dual presentation where FPQC is going to present our part of how this initiative is going to work, and then we're going to turn it over to the Joint Commission. I do want to introduce the team that you'd be working with if your hospital signs up. Dr. Linda Detman is our Associate Director for Program and Operation here at FPQC. Dr. Cole Greves is our obstetrical consultant. The two many primary people you'll be connecting with is Betsy Wood, who is our nursing consultant, and Yana Decoder, who is our program coordinator. So glad that you are here with us. And let's get started. All right. Our agenda, I'm going to give you a brief overview and welcome. Then we're going to go into the ACOG Obstetric Consensus Statement. We'll talk about FPQC funding of the program and application and how that works. And then turn it over to the Joint Commission, who will talk about their verification process and their application processes and resources. And we hopefully have left a lot of time for us to have questions and answers. Just to start out, if you're not familiar with the FPQC, we are really focused on all Florida's mothers, infants, and families having the best outcomes possible through respectful, equitable, high quality, evidence-based perinatal care. And we really see this idea of promoting maternal levels of care as a great step forward in trying to promote this vision. We are a partnership organization. We were formed by our partners. We are given direction and guidance by our partners. And so we look to them for guidance on how to do all that we do, including this program. I did want to give a heads up from the front. There is a new state statute that all Florida maternity hospitals are required to participate in 2 FPQC quality initiatives at all time. That got passed by the legislature this last session. We did not promote this or have any input into this. This was just, we were informed. But we did want to be clear. This initiative on levels of maternal care verification is not considered a quality improvement initiative at the hospital level. If that's what you're interested in, you should be signing up for our Perinatal Quality Indicator Project. We have our postpartum access and continuity of care kickoff next week. And then we also will have our spring one, and it says postpartum access to care. That should be saying social determinants of health. We will be having an initiative on social determinants of health starting this spring. Again, to be clear, this initiative on levels of maternal care will not count as one of the 2. I've been sitting on the Florida Maternal Mortality Review Committee for years. Dr. Cole Greves is our co-chair for this committee. And essentially what we're finding in the reviews is that many women are dying at hospitals with providers who are not really prepared to address and deal with their high-risk conditions. And this is happening nationwide. And so ACOG and the Society for Maternal Fetal Medicine have developed national standards for levels of maternal care based on medical conditions to help hospitals and the system of care better get women, when possible, to the hospitals who can best deal with their conditions. With that, the legislature has given funding to the Department of Health, who's contracted with us this year for one-time funding to do a 3-pronged strategy. 1, we are working on a proposal for the long term. We have an advisory group and others who are helping us give input for what this program should look like going forward in Florida. Second, we are doing a voluntary pilot hospital verification process with the Joint Commission. And there is funding this year for many of the Florida hospitals to automatically sign up and be able to be covered for part of the fees. And then third, we're going to evaluate how this pilot goes, your experiences, and what the process is like, so that we can take your experience and make sure the plan for the future is what's best for moms and babies. Here is our advisory group. We have hospitals, we have hospital networks, we have community representatives, we have obstetrical, nurse midwives, nurses, the health department, and then our team. Again, we hope to have this proposal put together by the end of this year. With that, I'm going to turn it over to Dr. Cole Greves. Dr. Greves is the chair of ACOG District 12, which covers all of Florida and is our lead ACOG representative here in the state. And we're pleased to have him not only be the co-chair of the Maternal Mortality Review Committee for the state, but also to serve as our OB consultant. And thank you, Cole.
Yeah, thank you, Bill, for that introduction to both levels of maternal care and myself. This, as you can see from the document up on the slides, this is the Obstetric Care Consensus. It's actually number 9 between the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine. It replaced the initial document, which was published in 2015. And it replaced it largely because as levels of maternal care was rolled out and discussed amongst communities that were looking into it, we learned that there were a few things that the initial levels of maternal care held that were somewhat drawbacks. Largely, these were limited to definitions of readily available and on-site, which were further defined in the new document, which you see listed on the screen there. So this is document number 9, Care Consensus number 9. And really, the idea behind levels of maternal care stemmed from, as Bill has mentioned, a recognition that women were dying and maternal mortality was increasing because oftentimes women would end up in facilities that weren't, through no fault of their own, adequately equipped to deal with the high-risk maternal condition. And certainly we've seen an increase in high-risk conditions in our obstetric populations over time. And one of the things that the levels of maternal care hopes to identify is facilities that are assigned into certain levels based on facility resources, human resources, and in addition, their ability to provide transfer or receive transfers, maternal medical transfers, obstetric transfers, and also provide education to lower level care facilities. So it's partly about defining what level an institution is at, and also about forging relationships between lower levels. Typically, these are level 1 and level 2 hospitals, with the upper levels, levels 3 and levels 4. And how these are defined really are based on specialty hospitals, subspecialty hospitals, regional perinatal levels of regional perinatal institutes of care. And these are different than kind of what typically would be defined as maybe a RIPIC center. Not all RIPIC centers would be level 4 facilities. Not all level 4 facilities will necessarily be RIPIC centers. I won't unpack the entire document going through what qualifies as a level 1, level 2, level 3, and level 4, but in essence, the level 1 hospitals are able to handle low and moderate risk obstetric patients. Level 2 can handle slightly higher risk, typically will involve some degree of maternal fetal medicine care potentially, and may need a different level of anesthesia care. Levels 3 and levels 4 then are going to handle your more involved high-risk conditions, placenta accreta spectrum, and perhaps early preeclampsia, patients who have more advanced maternal medical conditions. And then level 4 are really going to be your hospitals that are required to have an on-site intensive care unit managed by maternal fetal medicine and critical care. They're going to need to have transplant capabilities potentially, or neurosurgical or cardiac surgical capabilities. Not all 3, but one of those 3. Typically need to have a maternal fetal medicine division managed by a board-certified maternal fetal medicine physician, and some additional advanced trainings for some of the people in more directorship type roles. So really, again, the document in essence was designed to forge relationships between the levels, the hospitals at various levels of maternal care, to allow for increased education, easy medium for providing transport when patients who are of higher risk arrive at a lower level center that are less well equipped to deal with their condition. And then establishing some guidelines in terms of what types of care might be provided at the various levels. This document, again, was verified in 2021, so the same document that's number 9 out in 2019 was verified just recently.
Good morning. I want to go over, basically this is a two-part application. You'll be applying for the funding through FPQC, and you'll be applying for the verification site visit through the Joint Commission. When you apply, and Linda will be putting the link to the application in the chat. So when you apply, once we receive your application, we'll be sending out a hospital commitment letter, just to be sure that to be signed by your leadership, hospital leadership. Be sure that everybody's aware that FPQC will be paying for the verification visit and the first full year of fees for the Joint Commission. And then hospital will commit to pay 4 years, 2 and 3. You'll also commit to scheduling an on-site verification visit within 90 days of the completed application. Ideally, all of the site visits will be on the books by the end of January. Commit to completing the online evaluation survey and evaluation interview. Understand that you will be getting a bill by the Joint Commission, from the Joint Commission. FPQC can't reimburse the Joint Commission for the site visit until after the site visit has occurred. So just let your financial department understand that they will be getting a bill, do not pay it. FPQC will cover that cost. Acknowledge that FPQC and the Joint Commission will be in close contact throughout this process to be sure that the hospitals are online, that the process is smoothly occurring. FPQC will not be getting the report from the Joint Commission. We will be getting aggregate deficiency findings report. No hospitals will be identified, and we will be getting it by hospital levels of care. And then we'll be sharing this information with the Florida Department of Health. Again, it will be de-identified completely. Next slide. So the evaluation, as Bill mentioned, we really want this process to create the process that is best for Florida's moms and babies. And so evaluation of the process itself is a big part of this pilot project. So it's going to be led by a USF implementation science specialist. And every hospital that goes through the process will be receiving a online survey. And most of the first hospitals will ask that you participate in an online interview as well as the survey. The whole evaluation has to be completed by the end of the fiscal year. The topics, again, it's feedback from your experience. Tell us how the verification process has helped. And then give us suggestions on how to craft the future program to be as useful to the hospitals to improve the quality of maternal and infant care throughout Florida. So next slide. Now I want to introduce Jennifer Anderson, who is currently an Associate Director in the Department of Standards and Survey Methods at the Joint Commission. In this role, she oversees work directly related to the creation of the Joint Commission standard and the survey methods as part of the standards development process. Also, I want to introduce David Eikemeyer. He is the Associate Director of Certification at the Joint Commission. Mr. Eikemeyer has been with the Joint Commission for over 25 years. And over the years, he's worked with every Joint Commission accreditation program as part of marketing and business development teams. Last couple of years, David has been responsible for helping hospitals through all the steps in preparing for many different types of recognitions in certification and verification. Dave will be your main contact with the Joint Commission. His role is hand-holding, cheerleading, explaining the application process, guiding organizations on standard, the on-site process, timetables, and up to the last minute questions. So Jen, I'll hand it over to you.
All right, thank you. I just want to confirm that you can see my screen.
Yes, we can.
Awesome, thank you. So as Betsy mentioned, my name is Jennifer Anderson. I am an Associate Director in our Department of Standards and Survey Methods at the Joint Commission. It has been my job over the last probably 2 to 3 years to take that OCC document that Dr. Greves mentioned and translate that into Joint Commission requirements. So I'm really excited to be able to share this new program with you. If I can advance my screen. There we go. So just some general feedback and information about the program. As I mentioned, we literally took the OCC document between ACOG and SMFM and we converted it into our requirements for our what we call maternal levels of care verification program. Joint Commission will be doing the on-site surveys to perform the verification. This will happen every 3 years if you choose to continue, and it's open to any acute care hospital or critical access hospital who are otherwise compliant with the CMS conditions of participation and federal laws. And basically what that means is you do not have to be accredited through Joint Commission in order to be able to apply for this program. So the overall goal of this program, as Dr. Greves was mentioning, is to minimize risk to our maternal patients and to improve outcomes. And how we do that is we really, at the crux of it all, is we're looking at the resources available to your organization, the staff, which includes training and competencies, ensuring that you have the right equipment to care for the risk related to your patient population, and the right processes behind the work that you do. As Dr. Greves mentioned, there's 4 levels of care that we can assess. There's the basic care, specialty care, subspecialty care, and that regional perinatal health care center, which is outlined in the OCC document. So I won't go into this into great detail. What I know you want to know about is what it'll look like when we're on site and what do the requirements actually look like. So we'll get into that. So it's very similar, this process, to our current accreditation and certification process. We are planning for 1 surveyor to be on site depending on your level of care that you're applying for either 1 or 2 days. So if you are a level 1 or 2, you can expect a 1-day survey. Verification survey. If you're level 3 or 4, you can expect a 2-day verification survey. All of the surveyors who are doing these verification surveys have experience in, we either have our OB/GYN doctors or we have maternal child masters prepared and above nurses. Our sample agenda, just so you have an idea of what to expect, we'll have an opening conference like we do with our current programs. We will conduct some system tracers, but not all that you're used to. So we'll do an HR competency tracer. So we'll look at some of the providers, the nurses and other ancillary staff that are taking care of your patients. We'll look at their training and their orientation, and then we'll look at your providers' credentialing and privileging for those OB docs. We'll do a unit tour, so we'll be out and about talking to your staff, looking at your environment of care, and then we get into those individual tracers where we'll follow patients from prenatal care through discharge through the medical record. We also have an issue resolution in case there's anything that we need to discuss, and then we have our closing. And as I mentioned, this may occur over a 2-day period or a 1-day period. So our goals for this survey are really to assess the use of your clinical practice guidelines and best practices. how are you incorporating those CPGs and best practices into your policies and procedures? And then what we do is we look at those policies and procedures that are based on your CPGs, and we look for evidence of compliance with those while we're doing our individual tracer activity, while we're reviewing patient records. We'll talk, as I mentioned, we'll talk to your staff and to your providers. We look at your performance improvement plan. We may offer suggestions and education, or we may take some of those best practices you do, internalize them so we can share those with other organizations who may be struggling with something. And then again, as I mentioned, we identify any environmental risks that we may see and talk through all of that. So as I mentioned, we've traveled the country, and so we like to bring evidence-based practices to those who may be struggling in something. As I mentioned, during that HR system tracer, we'll look at staff education, the credentialing and privileging that occurs with your providers, talk about your shared decision-making, how involved your leaders are, look at your culture of safety, and then what sort of information are you giving to your patients? You know, when are you notifying them when to seek emergency care? What are you telling them to do while they're in the hospital? And that's all part of the entire tracer activity is what we call it. When we leave, we'll have a closing session. Everyone will be excited when we leave as we walk out the door. We know that happens. But before we walk out the door, you'll have a summary report. So you'll have an idea of exactly what we identified as opportunities for improvement. We'll discuss those findings. There will be absolutely no surprises when we leave. We'll let you know what you're doing really well, and we'll suggest areas that we see that you can potentially improve. As I mentioned, when we leave, you will have no surprises. You will be given a preliminary report with opportunities for improvement as they exist. And then after the visit, and this is again, same as our normal process, the organization has 60 days to submit evidence of compliance summary. We call those ESCs. We really like our acronyms at Joint Commission. And then once the ESC is accepted by our central office, you'll be given a letter that you can display and post wherever you would like that says that your OB unit has been verified at whatever level it is that you applied for. And then as I mentioned before, this is good for 3 years. So I wanted to give you all an example of what some of these standards may look like. And we developed this manual a little bit different than some of our other, what we would call our normal certification program. So typically when you apply for a certain certification, you only see requirements that are applicable to your organization. Well, with maternal levels of care, and we know how fluid things can be in OB, we wanted to make sure that everyone was completely clear on what was expected of each level of care. So you'll notice that these requirements build upon each other. So just an example of that, this talks about those support from ancillary departments such as anesthesia, respiratory, et cetera, and who needs to be available. And then we spell out for a level 1 facility, and I just highlighted radiology because we'll look at that. Too far. We'll look at that in the next levels as well. But level 1 has to have limited OB ultrasound with interpretation readily available at all times per the organization's policy. So we leave that readily available after talking with ACOG and our own experience with definitions and terms. We leave that up to the organization to decide what that actually means, and then we survey to your policy regarding that. And then as you can see, for the level 2, we go a little bit more in depth. So they have to have that limited OB ultrasound, but then they also have to have CT available, MRI, non-OB ultrasound imaging, and then standard OB imaging with maternal echo. And then again, builds again in level 3, they have to have that specialized OB ultrasound with fetal assessment, including Dopplers. So this information that you're reading right here came directly out of that OCC document. You'll be able to read it actually word for word and compare because that's what I had to do. That was my job. So just wanted to give you an idea of how the standards and the requirements build upon each other based on the level of care. But you will be able to see this. Anybody that is going for a verification regardless of what level, you'll be able to see what exactly would be expected. This is something else that we wanted to highlight. The ICU is a really important part of maternal levels of care and the availability of acceptance of maternal patients, whether they're pregnant or postpartum. Working in OB, I always knew that could be a topic of concern. And so one of the things here is that for level 3, they have to have a medical surgical ICU that accepts pregnant patients. And those ICUs are staffed by those critical care providers on site 24/7. And then we go a step further for that level 4, where we say that co-management has to be done with maternal fetal medicine. And so that includes at least daily rounds by the MFM specialist. All right, so that was just a sample of how we build upon each other with those requirements. And then I wanted to talk a little bit about the manual. It has its own separate manual. It's relatively short. We aren't doing physical copies of this manual. We're giving them to people as PDF versions, just because it's not a big manual. So it's much easier to get it via PDF. But there's 5 chapters. And so in the verification participation chapter, we call that our VPR chapter. This is really similar to our APR chapter and CPR chapter in our other programs. It's really what is required of us, or what are the laws and regs related to us coming on site? You know, you have to be truthful. You have to let us come in, right? And then the one that I wanted to highlight is that, as I mentioned, you permit the performance of this to happen. And the other one that I wanted to highlight that I talked about earlier is the fact that you do not have to be accredited through us, but you do have to be compliant with federal laws, okay? So if you're not a TJC accredited organization, you are still eligible for this great program. In our information management chapter, this is where we really focus on that continuity of patient health information. So think about when, you have a patient that either you can't handle at your facility or you're an accepting facility. You want to make sure that you get all of the appropriate information, or you send all the appropriate information so mom can get that best care and there's no gaps or delays in the care that's being provided. It goes both ways too. So after mom gets accepted into the higher level facility, that open communication with the facility that sent her there, so that everybody's staying informed. This also lends itself for process improvement and tracking. So, how are we doing with our transfers, or how are we doing with our care? It helps lend decisions for future decision making. If we've got this could be helping with even community planning, right? If we've got an area of the state that is considered, like a maternity desert, what can we do to help with that? So that's what this information management chapter focuses on. And this is just an example of one of those requirements. Continuity of information is maintained, and then basically that you have a plan in place to ensure that information is going both ways. What would this look like on site? So say our surveyor's there and we're reviewing a patient's record who got transferred to a higher level of care. We would look to see what got sent with that patient. And it may be as simple as documentation that says, prenatal care record sent with mom, and it would be right in the record. And then vice versa. If we're accepting patients, we would look for maybe that communication that's being sent to the referring facility while we're doing that tracer activity, just to give you an example of what that may look like. Our next chapter is called Delivering or Facilitating Care chapter. This is where we focus on that family-centered care, the development of those plans of care using risk identification and those evidence-based clinical practice guidelines. So what sort of risk identification are we assessing when we get a patient into our facility? Is it based on evidence, or is it something that your facility made up? Those sorts of things. So we'll be looking at that, looking at the care provided within the organization. Is it within the level of care that you're seeking? And then as Dr. Greves mentioned, it's that cross-cutting approach between organizations to make sure that mom is getting the correct level of care. So those transfer agreement so that everybody knows how to access, who to call if they have to have a transfer out, so we can get mom to where she needs to go as quick as possible. Making sure that that care is coordinated across the entire perinatal event. And so some examples of what this looks like is, making sure that the team, the interdisciplinary team, is assessing and reassessing mom's needs. And how we do that is making sure that the plan of care has an interdisciplinary approach, including the mom and family as appropriate. And then looking at those assessments, as I mentioned, those high-risk assessments, using those standardized tools and making sure that the team is doing those early risk assessment and then continuing those ongoing assessments as identified across the continuum. Performance improvement. So with the MLC program, it's different than our current certification programs and our accreditation program because we don't do a super deep dive into performance improvement. We make sure that the organization has a performance improvement plan, and we'll look to see what you're looking at, offer suggestions, but we don't do a super deep dive like we do with what we would with like a data session, if you're familiar with our accreditation program. So we do require that you track performance related to some certain topics, severe and maternal morbidity and mortality, the transport process in general, how can we continue to improve that? And then really whatever else that you would like to assess. Do you have an issue with episiotomies? And so your providers have decided that you want to track that. That's totally fine. We just have some that are required, but then the rest are up to you. And then when we're doing our, say our unit tour, and you have a board where you talk about your outcomes, or you have a binder where you talk about your outcomes, that's where we would look at that while we were on site. And then just an example of a requirement, the program uses its data, and then the element of performance, which is like how you become compliant with the requirement. We are asking that organizations use that data and compare it to other targets when they exist. So I don't know if that's something that the FPQC would help with, or if you're already doing that, I'm sure you are. But, comparing how you're doing with others is always a good motivation. And then our program management chapter, this is really where the bulk of those level-specific requirements lie. So this is where we'll talk about your resources, your personnel, and your training. And as Dr. Greves mentioned, we do focus on that relationship that's developed between the level 1s and 2s with those 3s and 4s. So coordination, communication, education, assistance with quality improvement efforts. And we don't say that, the level 4 clin spec has to go to the level 2 and provide education for them. That's not what the requirement is. It's just, if that level 4 has developed some sort of education material that was really helpful, maybe sharing that with the lower levels of care so that people have access to that excellent information that is already available. So again, another example of what this would look like. This is the clinical practices are originated from evidence-based guidelines, and then that you're using those guidelines to assess a mother's risk. And then this talks about some of the conditions that could be potentially assessed for those high-risk conditions, and that how we would look at that is we would look for your policy that says these are the things that we assess for according to risk. And then we would look for that when we are doing our individual tracer activity in the patient record. All right, so now that is it for me. I know it was like speed talking so that we had time for questions, but I would love to hand it over to my colleague, Dave.
Thank you, Jennifer. I hope everyone can hear me okay. I have just a couple of slides to talk about the steps involved for actually engaging with the Joint Commission and getting this in place and set up with your hospital. The first thing we see on here related to the application, you do want to obviously reach out to the Florida and request the funding. You basically have to get the funding agreement signed by someone at your hospital to get that approved. I'd also recommend that you contact us at the Joint Commission as you're working on all of these funding letters and everything else to get a copy of these standards. Make sure you have them in place and get started on the review, because you're going to need to look at them very carefully to be ready for the application step at the Joint Commission. Now, any hospital that is already Joint Commission accredited has what we call a Joint Commission Connect portal. Each hospital is unique. So you will be able to access what you need on that portal. If your hospital is not Joint Commission accredited, it's just one extra step to set that up for you. But everything related to our certification or verification process goes through this portal to start with the application process itself. And when you are ready for that, I'll be the main person to handhold as much as needed to guide you through this process online. It can be a little bit confusing the first time you look through it, but that's my role here, is to just guide you through whenever you're ready to go. And there will be a couple of basic things that you have to provide in this application process once you're ready to go. First of all is we will ask you for a readiness date. The state has given you some deadlines. We want to make sure that you are ready to go within that deadline. We will not come to see you until your readiness date. So it really does give you a little bit of control over the timing, but we'll try to come to visit you as soon after that readiness date as we can. The 30-day notice that's on here is just to tell you that this is not an unannounced review. You will get 30 days notice of the confirmed on-site date. So you'll know a month in advance when we're coming to take a look at the program. The on-site review, according to the funding, must be completed by next June at the latest. We certainly hope the early adopters are going to be working on it much sooner than that. Early next year for most of the reviews, I think, is what we're expecting, but we'll be working with you on all of those dates. So in the application, there is a separate section where we will ask you for a little bit of detail. One of the things we ask you to do is identify guidelines that you're following in the program. In most cases, you're going to start with the ACOG guidelines. You may or may not have more than that. The level 3 and level 4 are more likely to have other subsidiary guidelines for certain complicated issues, for example. And then we do have what we call a performance improvement plan questionnaire. We're going to ask you to give us some basic information on what you're doing for performance improvement and what your goals are. And I've got the next slide, we'll talk about that in a minute. But we want you to definitely get the application process started. And I'm the person who will help you with that. I know several hospitals have already gone through the requests for funding. So there's a few of you that I'm already talking to in the queue for this application process. And there are a lot more I'm sure will be coming in the next several weeks. Next slide, please. Jennifer, are you? Oh, there you go. So this is the one sort of complicated thing that the application requires. The performance improvement plan, like I said, it is a 5-question questionnaire where we want to get a basic overview of what you're doing for performance improvement, because that is always part of all of our reviews that the Joint Commission conducts. We're always going to talk to you about performance improvement. Where are your goals and your activities? So you will be describing the scope of the activities that you currently have in place. We'll ask you to describe who's involved in the management of these areas. We'll want you to tell us where you are as far as goals and objectives. These are completely yours to determine, and every hospital, of course, will be a bit different. I imagine that there may be some hospital systems where they're sharing goals across multiple hospitals, and that is also a good thing you'll be telling us about. And as more than one hospital in the system, if it is applying for this, we're obviously going to probably see some similarities across various hospitals in those systems. And then we'll ask you to, based on those goals you give us, we'll ask you to describe what are you working on to try to get some progress towards those goals. And then the last question on this plan is actually asking a little bit about how you report the information, how you delegate responsibility for the program's performance improvement. And when we talk about reporting information, we also want to see that you're reporting both up to your leadership on those key issues, as well as reporting to your staff, your team members on the improvement that they're all working on with you. Next slide. So how to get the standards? There are a couple ways to do it. One way is to just send a request through the email address, which we'll show in a minute. We can get you a PDF version of the standards. The other one is online, what we call our e-edition, and those standards are available through the Joint Commission Connect portal as well. So what you'll see are a few of the things that Jennifer just described, but the rail on the left is going to show you where you'll be finding it. Once you have access to this electronic version, you'll be looking under the July 2022 dates, and you'll see maternal levels of care. And then the list below are those 5 chapters that Jennifer described. So you'll look through each of these standards. You can print from here too if you need to. Sometimes it's easier to share that way, but you'll be clicking on each of these standards, getting a little bit more information. Some of these have multiple bullet points, some don't. So you want to really look at this very carefully. The very first step to understand, first of all, what level you are actually achieving is to look very carefully at these standards and do some self-assessment. So when you are applying, we will ask you to identify the level of care that you are applying for. And you want to make sure you have all the pieces in place. If you are applying at level 3, you want to verify that you have all the level 3 pieces in place, because that's what we're expecting to see. Next slide. And as we said at the beginning, the state is paying for some of this. This is a 3-year process. What you'll see every year out of those 3 years is an annual fee. And then only the first year, you'll see the on-site fee, which is covering a flat fee that covers the actual on-site visit to your program. The state is very nicely covering the first year fees, both the annual fee and the on-site fee. So at, for example, level 1, the state would be covering $4,275 for those top 2 lines. But your hospital is a 3-year process. Your hospital will each be required to then cover the annual fee for year 2 and year 3. So you'll see below, the total for level 1 is $8,275. The hospital's responsibility will end up being $4,000, but they won't be paying it until the 2nd year. And if you need some more information about any of the payment processes, feel free to reach out. We can identify or explain this a little bit more if you need some help on how these are billed and when and everything else. Next slide. So this is our general email address. Send your responses or your questions to verification@jointcommission.org. Among those requests, obviously, you could ask for a meeting with me or one of my colleagues. You could ask for the standards. You could answer or ask any questions that you have on anything you've seen today. We're happy to help and get all the information you need to get started effectively. And then obviously, if you want to reach out to Florida, that's the email to ask questions about the funding letter, etc. And I think that's all for me. I believe we're done with the presentation and it's time for questions.
Yes, thank you, Cole. Thank you, Betsy. Thank you, Jennifer, and thank you, David. The remaining time here is to help answer questions that you might have about the program, either from the Florida side or from the Joint Commission side. Please feel free to unmute yourself and to speak up verbally, or we have been trying to monitor the chat.
So we do have one question in the chat, and that asks, does this tie into the Joint Commission perinatal certification?
So they are 2 separate programs. The focus is a little bit different between this and the certification, whereas here we're really focusing on the resources, personnel, training, that sort of thing. And for overall care, whereas with the certification, we have some really specific things that we've incorporated into our new certification that's being rolled out in January. More deep dive into the quality. There's a data management session. So they complement each other really well, but they are different.
one question that got raised was what happens if you apply for a level and you don't meet that level? David, Jennifer, you want to answer that question?
Sure. So say you are applying for a level 3 and then we come on site and recognize that there are some pieces that are missing for level 3 and you're functioning more like a level 2. There's a couple of different options. The option 1 would be if there are things that are easily fixed. You can submit your evidence of standards compliance, that ESC, within 60 days. And then as long as that's accepted, then we would verify you as a level 3. But say after having a conversation, recognizing that maybe it's, a contract for an MFM specialist or something that you don't think you'll have in place within 60 days, you have 2 options there. You can either convert the visit to what we call an education visit. And so it would be, the reviewer on site providing education. The on-site service fee still applies, but then we could come back when you've got everything in place. Or you can then decide, okay, let's just go through a level 2 verification, and then we would assess you to the level 2 requirements.
Riz, did you have a question? Because I see your camera is up. We can take your question if you have one. There's a question in the box. What happens is FPQC will pay the first full year fees and the site verification. We will pay the Joint Commission after the site visit takes place. That is a positive for hospitals because, for example, if you apply now in this window and you're able to get through your application, you would then, you would get a whole first year where it's prorated this year. So you would get extra funding. If you apply and you don't get on until January, then it will cover your whole full year because they work on a calendar basis. Then the year 2 and 3 is left up to the hospital after that. Just as Betsy mentioned, though, you will get billed by the Joint Commission all the way along, and you just need to teach your billing people to ignore that you're in the FPQC program. The Joint Commission knows you're in our program, and they know as you complete the on-site visit before June, the end of June, you will be covered.
Hi, this is Tony Wynn from UF. I have a question. Is this level is my sense is that it also probably tie in a little bit with the neonatology level of care for newborn. So the clarification I would like to have is the level we apply for. Does it also have any relationship to the level of care for the newborn?
It does not. This purely relates to the mother's side.
But a lot of times for a higher level, like, I'm going to be taking care of a mom with maybe more critical disease, and there's a higher level of some delivery or some other complication. Wouldn't it be more or less tie into the neonate capability of that hospital?
Well, Cole may want to address this. My understanding behind the maternal levels was to try and get the mother's side up to the neonatal, because there were hospitals who were providing higher level neonatal care, but were not providing higher level maternal care. And so, yes, you would hope that they are of equal nature, but frequently some of the hospitals with higher level neonatal have not reached the level that they need to for maternal. I'll turn that over to Cole.
Yeah, no, that's correct, Bill. In fact, the document actually itself, the consensus statement actually addresses this very issue, and it specifically states that one is not entirely dependent on the other. But I think Tony makes a good point that typically, especially at your higher levels, it would be unlikely that a level 3 or a hospital would seek level 3 or level 4 verification if they didn't have a higher level NICU to provide care, since many of those moms may well be delivering early babies also in need of, or babies with anomalies in need of higher level neonatal care. However, this really was designed to address the issue of maternal morbidity and mortality. apart from the neonatal complications of the extremely preterm neonate and neonate with anomalous conditions.
This also does tie in, it's a good question related to the Joint Commission's perinatal care certification, because that does address both the maternal side and the newborn side. And one of the issues, one of the questions we'll talk to you about if you were looking into perinatal care is what level of nursery or NICU you have in place, and evaluate that you have all the pieces to serve those level of patients effectively. So that's a different animal, happy to talk to you about that. But it's the maternal levels of care verification really does concentrate on the maternal side only.
So this is Erica. So after the third year, so if the hospital, after the third year, then what happens? Like, what's next?
Well, from the
It is
Florida
up to
side,
you.
Erica, we have 1 year of funding from the legislature. That's it. We're proposing an ongoing program, but that will be up to the Department of Health and the legislature as to what that ongoing program will look like.
And as far as the Joint Commission side, it is up to you to decide to re-enlist essentially for another verification on-site visit at the end of the third year. And that's something we'll obviously be working with you down the road to see if you want to and how you would maintain this going forward for another 3 years.
Clearly, the whole idea of the advisory group is to help us talk about what the future should look like on the Florida side. If you have thoughts of that, please feel free to reach out to FPQC@usf.edu. We want to get your perspective on that. Part of us evaluating this program this year is to make sure that we get your all's experience and what you all think of the program as we try to make those plans going forward.
Thank you.
Other questions that might come up? Concerns? Just so you know, we're well positioned. I'm sure as you share this with others, questions will come up. Please feel free to reach out to us on the Florida issues. Please feel free to reach out to the Joint Commission on Joint Commission issues. If you're not sure, we stay in constant communication between the two, and we each will try to answer only our questions so we don't have confusion, but we are here to help and our staff to be able to do so. Again, our biggest encouragement to you is if you're interested in this is to get people moving early. Again, because the clock is clicking, it's out of our control. We are defined by this year in terms of having funding available, and it's a nice amount of funding available so we can cover many hospitals, but it's only for this year.
Well, I also wanted to point out that it is limited funding. So if you wait until the last minute, there is the potential that the funding will have run out.
All right. Well, we thank you for your time. We thank you for all that you do for moms and babies, and we look forward to hearing back from you and assisting you all in any way that we can.
Thank you.